The ankle is scoped. As the MRI suggests, there is a scarring. The impingement lesion has to be taken out. These patients often have a painful dorsiflexion. You assess the peroneals. You check for any tears if at all they are there, and then you do the Prosum Gold repair, where you put in anchors at their anatomical sites, and the ligaments are sutured back as a cuff. And you should again rule out coalition for these individuals.
So in a flexible flat feet, there is a visible arch when the child is not a child or adult, is not putting weight on it, but as soon as they put weight on it, it collapses flat foot. Then the arch forms back when they stand on the tip of the toes, and also when it dorsiflex the big toe, the arch forms back. It's called Jack's toe test, very essential for children.
And you can always compare to the other side to see if both sides are similar. So in this patient, the patient has some significant bulgus. And from the back, you can also see that there's forefoot abduction with a too many toes sign. So if you can see more than 2.5 toes, the patient is considered to have a significant forefoot abduction. But this is to be confirmed and on a more objective way via radiographs. Next, we want to check for silver skull test. The reason why the silver skull test is done is because we want to...
Do you want to do it right away when the child is still growing, or would you want to wait and watch and then do an osteotomy once and for all, once the physis has closed completely?
I want to do it after skeletal maturity.
Great. So if you're doing an osteotomy and the child is continuing to grow, and since the lateral physis is kind of open on this side,
should we plan surgical?
Angles are definitely not normal because the hallux valgus angle is 39 on the right,
39
on the left. The intermetatarsal angle is 15 severe on the right, 14 moderate on the left. The hallux valgus is incongruent, right? So incongruent would indicate that patient needs a soft tissue reconstruction.
Yes.
To get this phalanx reduced on the metatarsal head. Okay. So what sort of surgery? First, we do a soft tissue release.
Soft tissue.
So soft tissue release would be a McBride procedure. And what is that McBride procedure? Where we divide the transverse metatarsal ligament. We release the adductor tendon. We also release the we free this sesamoid complex from the metatarsal head entirely, and we also cut the capsule on the lateral side, right? So all this is done to reduce this phalanx congruently on the metatarsal to convert a incongruent hallux valgus into a congruent one, right? That is the first step of surgery. You're understanding what I'm saying?
Yes, sir.
Okay. And the second step of surgery is done to decrease this intermetatarsal angle, right? So this angle, as I mentioned, is 15 on the right. Okay. So we want to get this 15 to less than 10. So if you can do this correction and you can get this IM angle normal, that will be the goal of surgery. Okay. You agree with me?
Yes, sir.
Okay, great. So if this is a severe hallux valgus, moderate to severe hallux valgus requires something like a proximal osteotomy. So there are several names of these osteotomy. The most common one, the one that you normally see in your books, is called a scarf osteotomy, right? So this is the one that you normally see in your books and the one that you should be answering in your exams also, right? If it is, say, a mild hallux valgus, then you need to do a distal osteotomy.